Rahul, you may start.
So, endometriosis is a chronic inflammatory estrogen dependent disease where endometrial glands and stroma grow outside of the uterine cavity. 1 out of 10 women have endometriosis, and 30 to 50% have infertility or chronic pelvic pain. March is Endometriosis Awareness Month. And this year, we are joining the Endometriosis Awareness Month campaign in partnership with BSB Bioscience Philippines Incorporated through a continuing medical education live webinar initiative. Good afternoon, everyone. I am Dr. Micaela Buku, your moderator for this session. Before we begin, may I call on the Senior Product Manager for Women's Health of BSB Bioscience Philippines Incorporated, Mr. Raul Franco Ramos, to give his welcoming remarks. Go ahead, Mr. Ramos.
Hi, good afternoon, everyone. Dr. Micah, good afternoon to you, and thank you for saying yes to be our moderator this afternoon. My name is Raul Franco Ramos, Senior Product Manager po of Repro Medicine Women's Health, and we are BSV Bioscience Philippines, or Bharat Serums and Vaccines Limited, and we are a wholly owned subsidiary in India, where we also have manufacturing plants in the US and also in Germany. So today, we join the Philippine Society of Reproductive Medicine supporting this year's Endometriosis Awareness Month through this live webinar. So our reproductive specialists of the PSRM definitely knows how to determine the best treatment plan to women who are inflicted of this painful condition. And in BSV, we value this very much, and it is our little way of raising the awareness of endometriosis here in the Philippines. And remember that this is a campaign of BSV and the PSRM, and all throughout the month of March. So I hope that you can follow us in our social media platforms, especially with PSRM education, as we increase the awareness, and hopefully change of the culture will follow. So I hope that everyone stays on this presentation to learn more about this disease. And from BSV, we welcome you and we thank you.
Thank you so much, Mr. Ramos, for the warm welcome. Now may we call on our dear PSRM President, Dr. Debbie Guani Megizo, to formally open today's session. Ma'am Debbie.
Thank you, Dr. Buko, for that introduction. Good evening, everyone. As we celebrate Endometriosis Month, the Philippine Society for Reproductive Medicine has been having several activities to give awareness of this chronic disease. It is just timely as Raul approached us to partner with BSV for tonight's discussion on different medical treatment options for endometriosis. So we are fortunate to have two brilliant speakers, Dr. Basma Abdulrahman Adarwish and our very own Dr. Ina Irabon. So in behalf of the Philippine Society for Reproductive Medicine, I welcome all of you on tonight's webinar. Back to you, Micah.
Thank you so much, Dr. Megizo. We eagerly look forward to learning more about endometriosis and discussing new evidence in the management of this enigmatic disease. So it is my pleasure to introduce our speakers. Our first speaker has closely worked on minimally invasive surgical management of endometriosis with Dr. Roman Horace. She is a member of the French Board of Obstetrics and Gynecology and a fellow in surgical and minimally invasive gynecology. So aside from minimally invasive gynecologic surgery, she is also a specialist in high-risk pregnancies. So To give her talk on leuprolide acetate, an effective treatment strategy for endometriosis, we are privileged to have Dr. Basma Abdulrahman Darwish. Our second speaker is no stranger to us all. She has been part of the PSRM Board of Directors from 2019 to 2021. She is currently the Associate Editor of the Philippine Journal of Reproductive Endocrinology and Infertility and part of the peer review committee of fertility and reproduction, the official journal of Aspire. She is a medical specialist one at Hospital de Makati, and she also specializes in minimally invasive gynecologic surgery, as well as reproductive endocrinology and infertility. So to discuss medical management of endometriosis-associated pain in the Philippine setting, we are honored to have Dr. Ina S. Irabod. So without further delay, let us begin with the first lecture. Dr. Darwish, the virtual floor is yours. Go ahead.
If you may please just stop sharing so I can share the slides from my side, please. Okay. So good day, everybody. Thank you for the introduction, and it is my pleasure to be part of your webinar tonight. And so as part of the Endometriosis Awareness Month, I would just ask you to look around and count maybe 10 women, or think about 10 women you know, a sister, a mother, a friend, an aunt, and a cousin. It's almost probably certain that one of those 10 women will suffer from endometriosis. Jacques Danez, one of the pioneers, not only in gynecology, but in endometriosis specifically, once said that no woman is born with stage 4 endometriosis. And the image you see on the screen represents the probable natural evolution of endometriosis. So all adolescents have at least minimal lesions of peritoneal endometriosis initially, which is identified as stage 1 or superficial endometriosis. And in many cases, these lesions may remain minimally symptomatic until the onset of menopause. And in other cases, they are only an intermediate stage between more severe forms of ovarian endometriomas or even deep infiltrating endometriosis. Finally, in some cases, the appearance of the lesions does not change significantly, but the patients complain of multiple pains. Logic and clinical intuition would tell you that a woman that has a normal pelvis without any anatomic lesions should be pain-free. And the woman here with stage 4 endometriosis should be the one that is experiencing the most pain. But any of you who regularly treats and sees women with endometriosis knows that this is not necessarily true. There are a significant amount of women that have very advanced endometriosis with very little pain at all, and many women that have significant pain without any pathologic findings. And here is the classic picture, which you probably know, unfortunately too well. It would be this pain that patients would describe as a terrible pain during cycles, not that type of pain, of course, for which they can take a simple painkiller, lie down, rest, and it would go away. But that type of pain that would knock them down, successive visits to doctors, and with time, they would develop new symptoms, GI symptoms like nausea, bloating, fatigue, migraines, a constant battery of tests, blood work, CT scans, MRIs, endoscopies, colonoscopies, and everything would come back normal. While there is a lot we know about endometriosis, maybe we know that it is likely that retrograde menstruation plays an important role. We know that implant proliferation, neovascularization are very significant factors in the underlying pathophysiology of endometriosis. But to be quite honest, we really do not understand why it is that these issues may or may not lead to pelvic pain in certain women. The most simple and logical way would be to assume that endometriosis is a nociceptive pain condition. And nociceptive pain is defined as a condition in which pain occurs as a result of injury or inflammation to the outside of the body. And that injury or inflammation is perceived as it travels through the spinal cord all the way up to the brain to give a perception of pain. And it is quite logical that endometriosis should be able to do this because it has been well established that endometriosis involves direct infiltration of nerve fibers. There is increased inflammatory cytokines and chemicals that stimulate those nerves, and there is nerve cell proliferation. This model of nociceptive pain is very well understood. It is the underlying physiology of many acute pain issues, such as acute surgical pain, but we know that increasing evidence suggests that this model is really insufficient to explain the experience of chronic pain in women with endometriosis. The interview with these patients remains quite complicated, and I always insist on the good news. Your fertility is not affected with a stage 1 or a peritoneal endometriosis, and you might not need to undergo any complicated surgery, maybe neither now nor in the future. But of course, I have to tell them about other less good news. I would tell them that it will be very difficult maybe to get rid of your pains, that the pain can get worse and affect different organs, and that they might risk always having more pain or less pain until menopause, and sometimes in case of associated adenomyosis, hysterectomy is possible in the future. So what are our treatment options? Yes, medical versus surgical treatment maybe? Surgery is effective, especially in cases of severe endometriosis, where these patients most often see a clear benefit in terms of pain and spontaneous fertility. But on the other hand, in case of superficial endometriosis, the interest of surgery is much more debatable due to its transient and short-term efficacy. During a laparoscopy in a patient with superficial endometriosis, what you would observe are different types of superficial lesions. You can see florid red spots, white stars, coffee spots, peritoneal pits, some hypervascularized areas, black cysts, a bulky uterus, which is soft to touch with a much more rounded posterior surface than the anterior, maybe some round ligament insertions, which are displaced forward. But unfortunately, the surgical treatment of these superficial lesions has a minimal impact on the pain, and everyone can verify this by seeing the patient again 1 year later. So it must be said loud and clear that a patient with stage 1 or superficial endometriosis can be as, if not more painful than a patient with stage 4 endometriosis, because the stages of endometriosis are predictive for spontaneous fertility. That is, they have no correlation with the intensity of pain. And maybe you have probably already realized that patients with extended forms, highly inflammatory disease are not good candidates for surgery. And large peritoneal resections provide only short-term benefit, and the recurrences of the pain are constant a few months later. And those types of patients are the ones that could benefit more from continuous medical treatment with the aim of suppressing menstruation and therefore inflammation. So what is the role of medical treatment? The main role would be to control the symptoms. There is evidence that endometriosis can be suppressed by these medications by downregulating this active disease and causing inflammation to regress. Medical treatments can also be used in preparation for surgery, maybe limited to a time between 3 to 6 months before a surgical procedure, because this results in less bleeding and makes the surgery a little bit easier for the surgeon. And we recommend medical treatment after surgery for regression of the disease, and in some cases before IVF for a short period of a few months before a fertility treatment. There are various types. Simple pain medications fall into the first group, and these are really common things like paracetamol and non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac, etc. And they can be very effective in managing pain, but they do not get into the heart of the disease, and so they won't stop the active disease from progressing. Opioids could be an option, even though I would say less likely when it comes to non-cancer treatment, and especially that one of the side effects is constipation, which can make symptoms even worse in those already with endometriosis, and of course, dependency. Hormonal medications are mostly contraceptives or the gonadotropin-releasing hormone analogs. So hormonal treatments are used to act on endometriosis and they stop its growth. What they do is either they put you in a perimenopausal state that is similar to pregnancy, and they all have a contraceptive effect. So they are not suitable for those who want to get pregnant unless there is need to take it before medically assisted treatments. Most of them will be similar in their effect in treating endometriosis. So the choice is based on how well a patient tolerates some of their side effects. Combined oral contraceptives is one of the most common contraceptive methods, and it contains both estrogen and progesterone in a synthetic form. They resemble female hormones, which are naturally produced by the body. And what these do is that they stop the menstrual cycle completely and they inhibit ovulation, which is really an important part of controlling endometriosis. They also suppress the amount of estrogen in the bloodstream, meaning that they do work well in suppressing endometriosis implants, and they sometimes obtain some regression of the disease. One of the best ways of managing endometriosis is to limit the number of menstrual cycles or to completely suppress them. And you can do this with a combined oral contraceptive pill by taking the packs back to back. But one of the side effects is spotting or some withdrawal bleeding when you take the packs in this way. And this is where I recommend what I call as the flexible extended use. What I mean is that the pill is taken continuously until a woman experiences some important spotting or withdrawal bleed. And at that moment, the pill can be stopped for around 4 to 5 days and restarted thereafter. And I always tell my patients that having 3 to 4 cycles per year is maybe better than having 12 cycles in controlling your symptoms and in controlling the progression of the disease. Progestogens is another type of hormones that would also mimic pregnancy. And what happens is that they replicate the normal female hormone progesterone, but in a synthetic manner. So what it does is that it causes the endometrium to thin out, which is very similar to the endometriosis in plants, and it causes them to completely regress and become very inactive and so stop growing. And that is why about 40 to 60% of women do not get any periods with progesterone treatment. And those are usually taken continuously, and they are very safe to take up to menopause. Some progesterones which are available in the market, we have the desogestrel, which is one of the most common mini pill. These are tablets that you take every day with no break. Most women do not have a period, or they might experience some light painless bleeding. On the other hand, we do have the hormonal intrauterine contraceptive devices, and this is another common progestative method. Usually the contraceptive device is licensed for 5 years for contraceptive label, but I would say in those with endometriosis, it needs to be changed earlier because progesterone does start to wear off towards the end. Keep in mind that the progesterone IUCDs fail to inhibit ovulation in the majority of cases, which in my opinion is an important part of suppressing endometriosis. We also have Depo-Provera injections or tablets, and this is also another option. A newer progesterone tablet is the Dianogest, and it is not very different than other progesterones, probably has lesser side effects when compared to others, and it has been designed specifically for endometriosis. But one of its main side effects, even by experience, is vaginal spotting. And also keep in mind that it seems to reduce the bone mineral density, so caution in its use for long-term without follow-up or add-back therapy. Now we move to drugs that mimic menopause, and these drugs tend to be more powerful and strong. They stop the production of the hormones FSH and LH, and they cause the ovaries to switch off, and so they temporarily cause the ovaries to stop producing follicles and completely reduce estrogen. So this results in the endometrium and the endometrial cells not to grow, and the periods will stop completely with this treatment. And specifically speaking about Lupron or Luprodex, this is usually given as a 3.75 milligram 1 month injection or an 11.25 milligram 3-month injection. The reason why those treatments are such good medications is because they drastically reduce estrogen levels very quickly. And this gives patients really rapid control of their symptoms. Even patients with severe symptoms might be able to keep resolution of their symptoms within weeks with such a treatment. The downside to the medication is that the low estrogen can result in quite disturbing menopausal side effects, the most important being hot flushes, night sweats, mood disturbance, and thinning of bones as demonstrated on a bone mineral density test somewhere around 20 weeks or 6 months of treatment. Nowadays, what we do and what is recommended is an add-back therapy, or in other words, an HRT, alongside the injections in order to make use of this useful medication to improve unpleasant symptoms, quality of life, and maintain bone density. There is no evidence that giving HRT with the injections flares up the disease and does not treat endometriosis. To note, the side effects, if present, are temporarily and they usually wear off a few weeks after treatment. So even though guidelines recommend the use of analogs for a duration of 6 to 12 months in order to reduce the impact of side effects, you might sometimes need in certain cases to prolong the treatment, especially in women approaching menopause, who would want to avoid surgery that might include hysterectomy and bilateral adnexectomy. So if we are looking at a longer term treatment, what we recommend is an add-back therapy alongside and a follow-up of bone mineral density every 1 to 2 years. So Lupron being one of the oldest gonadotropin-releasing hormone analogs in the market and one of the most widely used for the treatment of endometriosis in human beings, has been largely studied in adults. Coming back to young girls in their adolescence and by understanding the natural history of endometriosis, we believe that endometriosis may only start by minimal lesions at that age, where surgical intervention plays no treatment role, whereas medical treatment in this group of young teenagers is the most ideal treatment. That is not only to resolve symptoms, but also to suppress the disease. So medical treatment nowadays is being more investigated in such an age group. Diagnostic surgery, I would say, is usually not necessary in such an age group, and empirical first-line hormonal treatments like oral contraceptives and progesterones can be used. It is only upon failure of first-line treatment that a surgical diagnosis is necessary before initiating the second-line treatment, which is the gonadotropin-releasing hormone analogs, which have been now in a number of articles studied, especially by the group of Gallagher and his co-workers, who have reported about their investigations on the effectiveness and safety of gonadotropin-releasing hormone agonists, of course, with an add-back therapy in adolescents. And in almost about 50% of young women have rated that the gonadotropin-releasing hormone agonists plus add-back has been the most effective hormonal medication for treating endometriosis pain. In adults, gonadotropin-releasing hormone analogs have widely been studied, and literature shows its superiority on other medical treatment methods, especially in times of relapse or failure of first-line treatments. And now it is clear that an associated add-back therapy allows for a longer therapeutic duration, up to 12 months in most studies. In the study of Deben Wu and his team, they have shown that add-back therapy does not reduce the efficacy of using gonadotropin-releasing hormone agonists for the management of endometriosis. And in an RCT by the team of Zupi, he has shown that the add-back therapy allows the treatment of women with relapse of endometriosis-associated pain for a long period more safely, with limited bone mineral density loss, good control of symptoms, and better quality of life compared with gonadotropin-releasing hormone agonists alone or combined oral contraceptive pills. I spoke at the beginning of my talk about pain physiology, and that it is not very well understood in the patients with endometriosis. It is as if the same stimulus would not trigger the same bell in a normal woman as it would in a woman with endometriosis. And one of the reasons that would make us believe in this is, well, first, as we talked about earlier, there is little, if any, correlation between the extent of disease and the severity of pain. Second, medical therapies that are directed specifically at the endometriosis lesions are non-specific and actually treat many other causes of pelvic pain. So for example, one of the FDA-approved treatment for endometriosis, which is gonadotropin-releasing hormone agonists, they are effective therapies for actually many other conditions, including cyclic irritable bowel syndrome and pelvic pain without endometriosis. So what pain physiologists suggest is that in these patients who have chronic pain, there is some sort of imbalance in the central nervous system, such that there is either or a combination of increased facilitation or decreased inhibition that is associated with this state of chronic pain. So for patients with superficial endometriosis, I practically no longer use the term endometriosis, but that of chronic pelvic pain, which seems to me to be much more representative of what is happening in their body. So indeed, the clinical picture is much more complex, and superficial endometriosis represents only a small piece of the puzzle because it is most of the time associated with other conditions, most common of which are interstitial cystitis and irritable bowel syndrome. So urinary symptoms are common. Imaging does not find any bladder endometriosis lesions because the real cause is the bladder pain syndrome. And these symptoms are usually permanent, but with a noticeable worsening during menstruation in the form of an urination day and night and the impression of never completely emptying the bladder. So there is some sort of urinary hypersensitivity. Somewhat painful symptoms also concern the digestive tract. Imaging examinations, laparoscopic findings do not find any digestive endometriosis lesions, but the symptoms seem to resemble that of an irritable bowel syndrome, and they increase with cycles. We studied the frequency of digestive symptoms in patients with painful superficial endometriosis, and in reality, the vast majority of women with chronic painful pelvis, and we observed that a high frequency of them suffer from diarrhea, dyschezia, and constipation, and sometimes symptoms which are comparable to those encountered in women with deep or colorectal endometriosis. This means that the presence of digestive symptoms in a patient with endometriosis does not mean that one should automatically suspect a colorectal endometriosis. And this is where a multidisciplinary approach is applicable. And this is where continuous medical treatment, and maybe especially the gonadotropin-releasing hormone agonists, which seem to work even though not necessarily targeted only at endometriosis lesions. So this multidisciplinary approach, of course, includes a gynecologist, includes a gastroenterologist who would deal with the digestive symptoms, maybe of an irritable bowel disease, a urologist who would deal with symptoms of interstitial cystitis, and then of course we can refer patients to pain centers where more dedicated painkillers, neuropathic treatments, acupuncture, or nerve blocks can be very helpful. And I would say that in those patients, pelvic floor physiotherapy, helping to release the tension in the muscles, usually works very well. And not to forget the cognitive behavioral therapy in those patients. When surgery is necessary, mainly in cases of deep infiltrating endometriosis involving the rectum, vagina, bladder, ureters, or even the diaphragm. Well, in this talk, we're out of the scope to discuss the indications of surgery, but when a surgery is required for the treatment of advanced deep endometriosis, studies are limited, but strong expert recommendations acknowledge the preoperative use of gonadotropin-releasing hormone analogs for a short period of time in preparation for surgery, as this seems to reduce inflammation and facilitate surgery. So I myself and the team with whom I worked would never operate on deep endometriosis without at least a 3-month period of a gonadotropin-releasing hormone agonist preparation, which can be extended up to 6 months in very severe and expected to be challenging surgeries. I'm one of the believers in that medical treatment of endometriosis post-surgery is an obligation rather than a mere option. So the team of Horace Roman, my always mentor in the field, has just released the results of a 7-year follow-up of women operated for rectal endometriosis. And the study reported long-term satisfactory digestive function. The overall risk 7 years after surgery of rectal nodule recurrence is as low as 3.5%, and the risk of reoperation, mainly for pain relapse, is about 14.5%, in whom 26% were required for reasons of IVF management, that is, in women in whom continuous medical therapy was interrupted. So in severe deep infiltration endometriosis surgery, a gonadotropin-releasing hormone agonist is preferred to be continued initially for a few months post-surgery, as it is the most powerful in reducing inflammation, and it can then be followed with any other medical treatment of choice. So to bring new data to the topic, I would like to share with you our experience in the management of a 41-year-old patient who presented to our clinic with a 6-centimeter endometriosis nodule in an episiotomy scar. So this was a woman who had given birth twice, 18 and 13 years before, and had at every birth an episiotomy performed each time. So a year after the second delivery, the patient started to feel a small swelling at the episiotomy site. And then 10 years later, when she completely abandoned contraceptive pill intake, she observed rapid growth of the swelling, which became larger and more painful during menses. So gynecological examination revealed a solid tender mass of about 5 to 6 centimeters in diameter on the episiotomy site and close to the internal anal sphincter. And biopsy of the lesion revealed multiple endometriosis foci surrounded by some fibrous tissue. So the MRI, as you can see on the left, shows a large endometriosis nodule of about 6 by 4.8 centimeters. And an endorectal ultrasound revealed the mass in close contact with the anal sphincter, but with no true infiltration of the sphincter. So we thought that this wide excision, which would have led to an uncertain aesthetic result. And so we proposed first-line treatment this time by gonadotropin-releasing hormone agonist, and of course with an add-back therapy, in order to induce prolonged therapeutic amenorrhea. So 3 months later, the patient was completely pain-free, and the treatment was thus prolonged for a year. And the patient was reviewed yearly thereafter with follow-up MRIs before every visit, clinical examination, and an assessment for bone mineral density. So the MRI examinations showed progressive, significant reduction in the nodule size, and finally, at 3 years later, an overall volume reduction from the baseline by about 33%. Bone mineral density was assessed yearly, and it showed unchanged normal results. So 3 years later, the patient was asymptomatic and had not experienced any adverse effects. Clinical examination showed a significant reduction in the tumor size with a lack of tenderness on palpation. So even though the nodule size reduced significantly, it could have allowed a less morbid surgery, but because of the patient's desire and entire satisfaction with the positive results obtained from the medical treatment, it was decided together with the patient to carry on with the therapy up to menopause. But because the patient could not afford for the high expenses of the treatment, and because, satisfaction was obtained with medical treatment, so it was thought to continue treatment with progesterones thereafter until menopause. So gonadotropin-releasing hormone here was administered for 3 years, and it was followed by significant reduction in the nodule volume, as I mentioned before, by 33% of the baseline value. So there are other studies, of course, and there is a recent randomized controlled trial by Angioni and his team who showed that the gonadotropin-releasing hormone agonists who were administered in patients with incomplete resection of deep endometriosis allowed for an improvement in pain, similar to that recorded in women with complete surgery. But of course, we do understand that favorable outcomes disappeared shortly after finishing the treatment, leading to a conclusion that medical treatment is a valuable tool when the main goal is reducing symptoms resection of endometriosis implants, and when it is administered continuously. So here we administered the gonadotropin-releasing hormone agonist until a significant reduction in nodule volume was achieved, and there was total disappearance of symptoms. And this allowed the administration of medical treatments by progesterones after that, a decision which was made, as I said, together with the patient, and that was the patient's desire. And we also know that one of the major adverse effects of gonadotropin-releasing hormone agonists is the loss of bone mineral density, and therefore it is recommended as a second-line therapy, usually with an administration from 6 to 12 months. But to prevent the side effects, add-back therapy should be routinely used without impairing the therapeutic results. And so there are several authors, I mentioned them before, who have reported longer time administrations of GnRH agonists in combination with add-back therapy with no adverse effects. So on this basis, we can say that exclusive medical therapy can be used up to menopause in older patients who present with deep endometriosis, in which wide excision can lead to unfavorable functional or aesthetic outcomes. And when our choice is a GnRH agonist, we perform yearly assessment of bone
Sorry,
mineral
Dr.
density.
Basma, just sorry to disturb you, but I think the slides are not moving. Can you please stop and reshare your screen?
Sure, I still did not move them. I'm still on the same slide.
Oh, thank you.
Okay. Yeah, so I would say that we would perform a yearly assessment of bone mineral density to evaluate the absence of risk of osteoporosis. And up to date, we did not experience any patient who had had medical treatment disrupted because of abnormal bone mineral density results. And finally, again, with the team of Horace Roman, we have an RCT called MEASURE, or in French, it's called MESURE, which compares the efficacy of medical and surgical treatment in rectal deep infiltrating endometriosis, where we have enrolled patients over 35 years with rectal endometriosis in whom no further pregnancy desire is present. So we have divided them into women who have been managed exclusively by medical treatment, and those will be compared to those managed by surgery and post-operative medical treatment. So the results will be analyzed in terms of digestive outcomes, GI quality of life, and improvement of pain. So the patients have already been recruited, and we still have a year more to go for the analysis of the results. So hopefully I can come up with the results for the next Endometriosis Awareness Month 2023. Thank you.
Thank you so much, Dr. Darwish, for such an insightful and comprehensive lecture. So please, I would like to invite our attendees to enter their questions in the chat box so we can ask them later during the open forum. Thank you once again, Dr. Darwish. So moving on, we'd like to call on our next speaker to talk about medical management of endometriosis-associated pain in the Philippine setting, Dr. Ina Iraban. The virtual floor is yours. Go ahead, ma'am.
Hi, good evening. This is Dr. Ina Iravan, and for the next 20 minutes or so, I shall discuss the medical management of endometriosis-associated pain in the local setting. Here's the outline of my lecture. So I first do a quick review of the pathophysiology of endometriosis-associated pelvic pain, and then go on to discuss the treatment guidelines for endometriosis-associated pelvic pain, as well as the local practice on the management of this condition. So we all know this. No? Endometriosis is defined as the presence of functional endometrial tissue outside the endometrial cavity. And these ectopic islands of endometrium are actually non-neoplastic and hormonally responsive. Now, the most common sites of pelvic endometriosis are seen in this picture here, with the ovaries being the most common site for endometriosis and seen in about 60 to 75% of women. Endometriosis has such a wide-ranging and pervasive sequela that it has been described as nothing short of a public health emergency requiring immediate action. The WHO actually reports that endometriosis affects roughly 10% or about 190 million women of reproductive age, even women, not just women, but also girls, no, globally. And more than 4 million reproductive age women have been diagnosed with endometriosis in the United States alone. And as daunting as this number is, it only tells us part of the story, as an estimated 6 out of 10 endometriosis cases are or still remain undiagnosed. And thus, millions of women out there may experience repercussions of endometriosis without the benefit of understanding the cause of their symptoms or given appropriate treatment. Now, locally, based from the POGS data from 2019 to 2021, endometriosis ranks as the third most common indication for gynecologic admissions. And as you can see here in this graph, it actually comprises 10% or 9% of the total gynecologic admissions in the past 3 years, behind AUB and benign tumors of the uterus. Now, the typical patient with endometriosis is in her mid-30s, is nulliparous and involuntarily infertile, and has symptoms of secondary dysmenorrhea and pelvic pain. But it must be stressed that symptoms and signs may be extremely variable, and the classic symptom of endometriosis is pelvic pain. However, in clinical practice, the majority of cases are not classic. And this chronic pelvic pain often disrupt the social, professional, academic, and economic potential of our young women. And living with severe, cyclic, or continuous pelvic pain, or the threat of its return, often for decades, can also lead to anxiety and depression among these women. Another key source of stress, of course, will be associated with endometriosis, is the potential compromise of current or future fertility. The presentation of endometriosis is complex and heterogeneous, and symptomatically, it includes several hallmark yet non-specific types of pelvic pain and an increased risk of fertility as well as prevalent fatigue. Endometriosis is a lifelong disease, and the course of which we term as endometriosis life. Recently, the definition of endometriosis has evolved to one that is more patient-focused and takes into account the cellular and molecular origins of the disease, its natural history from teenage years to the menopause, its complex, chronic, and systemic nature, the variety of tissues involved, including the involvement of the central nervous system, and the need for treatments that address long-term suppression of ovulation. So aside from the inflammatory mediators, such as the pro-inflammatory cytokines, chemokines, and also the strong topographical relationship between endometriotic foci and nerves with perineural and intraneural invasion, another theory that can explain the severe chronic pelvic pain in endometriosis is the central sensitization pathway that postulates that repetitive and persistent peripheral stimuli contribute to central sensitization and myofascial pain. And the effect of central sensitization can explain the common coexisting chronic syndromes characterized by pain, such as the painful bladder syndrome, vulvodynia, myofascial pain, and irritable bowel syndrome. Furthermore, central sensitization, which can become autonomous and occur independently of the peripheral stimulus, is associated with changes in the regional gray matter volume within the central pain system and with altered brain chemistry. And so structural and functional changes in the central nervous system neurons have tonic activation and may be hyper-responsive to even mild stimuli. And as such, pain symptoms should be treated without delay in order to avoid the occurrence of changes in the central nervous system. So Professor Chaperon, in his article, always emphasizes that pain symptoms should be treated without delay to avoid central sensitization, as this can become autonomous, occurring independently of the peripheral stimulus, and can explain a coexisting chronic pain syndrome. Now, here in the local setting, as it is in other parts of the world, the diagnostic challenge in endometriosis is multifaceted, and symptoms such as pelvic pain, dysmenorrhea, dyspareunia, and even infertility are very nonspecific, and this can be attributed to many other conditions. Moreover, such pain can be associated with non-gynecological symptoms such as UTI or even digestive conditions. In addition, these symptoms are often not discussed openly by our patients because of the fear of stigmatization. And furthermore, awareness or understanding of the process is poor on the part of the general public, our employers, and even our healthcare professionals. So, symptoms occurring during adolescent period might be overlooked even by our healthcare professionals. And of course, there's no specific biomarkers in the diagnosis of endometriosis. And here locally, we also have to include the high cost of consult, workup, and medical treatment as a very important factor in the health-seeking behavior of our Filipino patients. And so because of all these factors, the average delay between the onset of symptoms and the diagnosis of endometriosis is roughly between 7 to 10 years. No? And you can just imagine the progression of the disease in that time span. So let's go now to the management of endometriosis. So Professor Chaperon always emphasizes that endometriosis is a chronic inflammatory disease that requires lifelong management. And as the endometrium is diseased in women with endometriosis, the patient is endometriotic for her entire life. And this is what we call the endometriosis or the patient's endometriosis life. And for this key reason, ultimately, the therapeutic strategy needs to have a long-term perspective and not to be limited to immediate and systematic surgery after diagnosis. The challenge, of course, is how to best determine the moment to perform surgery, which ideally should only have to be done once during the entire endometriosis life. The determination of the best time to perform surgery is one of the main indications for long-term medical treatment. So currently, there is no cure or curative treatment for endometriosis, and the clinical management of symptoms such as pain is through medical or sometimes surgical measures. And medical management follows the basic principle of reducing inflammation, suppressing ovarian cycles, and inhibiting the effect of estrogen. So endometriosis should be viewed as a chronic disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. So again, Professor Chaperon emphasizes that the modern management of endometriosis should be patient-focused rather than focus on the endometriotic lesions. And he also emphasizes that medical treatment for endometriosis can be administered or can be started even without histological confirmation. Here are the objectives for the long-term therapy of endometriosis. Of course, that's to alleviate endometriosis-associated pelvic pain, to preserve fertility, prevent recurrence, maintain treatment adherence, avoid bone mineral loss, and of course, eventually to improve the quality of life of our patients. And here are the medical options in our treatment armamentarium for endometriosis-associated pelvic pain. So medical treatment is recommended to be the first therapeutic option for our patients with pelvic pain who have no immediate desire for pregnancy. And the choice, of course, will depend on the safety profile of the medication, its tolerability for our patient, and of course, cost is always a big factor when considering treatment for our patients. Now, for this lecture, I did just a quick survey of 200 local OB/GYNecologists just to give me an idea how they actually manage their patients with endometriosis-associated pelvic pain. Of course, this number just represents less than 10% of the total OB/GYNecologists in the Philippines. Okay, so for the first question, what are the factors do they usually consider when recommending or prescribing medical treatment for patients with endometriosis-associated pelvic pain? And majority, or 87.5%, answered that they follow the recommendations of experts or recommendations from the local or international clinical practice guidelines. And that's very good to know that our OB/GYNecologists actually listen to what our experts recommend or what the evidence say about the management of endometriosis. And this is followed, of course, by affordability or the cost of treatment and patient preference. Now, from these factors, let us now look at how they actually manage endometriosis-associated pelvic pain. So the next question would be, what is your preferred first-line medical treatment for your patients with endometriosis-associated pelvic pain? And majority, as you can see here, 80% prefer giving the Unogest. That's a progestin. And this is followed by GnRH agonist in about 38.6%, and followed by NSAIDs and COCs. Now, do these treatments follow international practice guidelines? Let's see. Now, ESHRE released their latest guidelines on the treatment of endometriosis just this year, 2022. And the ESHRE guidelines actually strongly recommend offering women hormonal treatment as one of the options to reduce endometriosis-associated pain. Now, this hormone treatment can come in the form of combined hormonal contraceptives or COCs, progestins or progestogens, GnRH agonist, or GnRH antagonist. However, the GDG or the Guideline Development Group recommends that the clinicians should take a shared decision-making approach and take individual patient preferences, drug side effects, individual efficacy and cost, and of course, local availability. They have to take this all into consideration when choosing treatments or hormonal treatments for endometriosis-associated pain. So let's look at the progestins. Okay, so the ESHRE guidelines strongly recommend prescribing women with progestogens to reduce endometriosis-associated pain, but the clinicians should also, of course, take into consideration the side effect profiles of this drug. And here are the two systematic reviews that served as the evidence for the Guideline Development Group, which says that the progestins actually are effective therapies for the treatment of painful symptoms of endometriosis. Now, how about GnRH agonists? Remember, in the results of the survey, the GnRH agonist came in as the second most common option among the local OB/GYNecologists. So the ESHRE guidelines actually strongly recommend prescribing women with GnRH agonists to reduce endometriosis-associated pain, although evidence is limited regarding the dosage or the duration of treatment. And the guidelines, or the ESHRE guidelines, also recommend that GnRH agonists be prescribed as a second-line treatment, second only to hormonal contraceptives or progestins, because mainly of their side effect profile. And clinicians also should consider prescribing combined hormonal add-back therapy alongside GnRH agonist therapy to prevent bone loss and hypoestrogenic symptoms. And so these are the two published studies that they based their recommendations from, and which showed that GnRH agonist is effective in reducing endometriosis-associated pelvic pain. How about analgesics? No? From the survey that we did, NSAIDs came in as the third most common option. And the ESHRE guidelines actually recommend NSAIDs and other analgesics to reduce endometriosis-associated pain, although they consider this as a weak recommendation with very low quality of evidence. Now, for the next question in the survey, if the first-line medication is not available or the patient could not afford it, which of the following do you actually recommend as an alternative medical treatment for your patients with endometriosis-associated pelvic pain? And as you can see here, majority are actually giving DMPA. No, that's dipomethylhydroxyprogesterone acetate, followed by COCs, NSAIDs, and other progestin-containing pills. Others, or just a minority, uh, give etonorgestrel implants and selective progesterone receptor modulators. And what do the guidelines say about these treatments? Now, the ESHRE guidelines actually strongly recommend prescribing women with combined hormonal contraceptives, whether in the form of oral, vaginal ring, or transdermal treatment, to reduce endometriosis-associated dyspareunia, dysmenorrhea, and non-menstrual pain. And women suffering from endometriosis-associated dysmenorrhea can be offered the continuous use of combined hormonal contraceptive pills. And these are the 3 systematic reviews which the guideline group based their recommendations from. And all the systematic reviews consistently showed that there is actually significant, that OCPs or COCs actually significantly reduce endometriosis associated pelvic pain. So as you remember, or as you recall from the results of the survey, some of our OB-gynecologists actually give subdermal implants. No? So what does the guideline say about this? The ESHRE guidelines strongly recommend prescribing women with either LNG-IUS, that's levonorgestrel releasing intrauterine system, or etonorgestrel releasing subdermal implant to reduce endometriosis associated pelvic pain. Now, how about aromatase inhibitors? Now, based on the survey that I did, aromatase inhibitor is not a very common or popular choice among our OB gynecologists. So what does the ESHRE guidelines say about this? They actually strongly recommend giving aromatase inhibitors in women with endometriosis associated pain that is refractory to other medical or surgical treatment. No? And you can also give aromatase inhibitors in combination with oral contraceptives, progestogens, GnRH agonist, or GnRH antagonist. And here are the evidences for that. Now, these are the studies from which the ESHRE guidelines base their recommendation from, and all of which showed that aromatase inhibitors effectively reduce the severity of endometriosis associated pelvic pain. How about GnRH antagonist? None of our respondents actually chose GnRH antagonist as part of their treatment armamentarium, whether as first line or second line. However, the ESHRE guidelines also recommend giving GnRH antagonist as a second line drug for endometriosis associated pelvic pain. However, this is just a weak recommendation from the ESHRE guidelines. And finally, danazol. Okay, none of our respondents chose danazol as a treatment for endometriosis associated pelvic pain, and that's good because the ESHRE guidelines actually do not recommend oral danazol as a treatment for for endometriosis associated pelvic pain. However, they recommend danazol only if no other medical therapy is available. And the reason for this is because of the danazol's severe side effects, most particularly acne, edema, vaginal spotting, weight gain, muscle cramps, deepening of the voice, and increase in the facial hair. We have to remember, of course, that danazol is a steroid, a synthetic steroid that is derived from ethinyl testosterone and has a very high affinity to the androgen receptor, and thus thereby producing this unwanted severe side effects. Now, for the last question, when do you usually refer to an REI specialist regarding the management of endometriosis-associated pelvic pain? Majority of our local OBGYNs answered that we refer when patient is not responding to our initial treatment, and this is followed by the answer when patient needs surgery or laparoscopy. And this is really very reassuring for us that our local OBGYNs actually refer to an REI, and we encourage everyone to refer their patients to an REI specialist for co-management, especially when the initial treatment, if the patient is not anymore responding to your initial treatment, and most especially if the patient is desirous of pregnancy. Of course, this is for immediate and proper treatment of our patients with endometriosis. So in summary, the key concepts that we have learned from this lecture are the following. So endometriosis is a chronic inflammatory disease that requires lifelong management, and pain symptoms should be treated without delay to avoid central sensitization, as this can become autonomous, occurring independently of the peripheral stimulus, and can explain coexisting chronic pain syndrome. And medical treatment should be emphasized as the first therapeutic option for patients with pelvic pain who have no immediate desire for pregnancy. And from the results of our mini survey, we learned that Filipino OB-gynecologists consider expert recommendations, cost, and patient preference as the important factors in managing endometriosis, and that we also learned that the Unogest, GnRH agonist, and COCs are the top choices for the first-line treatment for endometriosis-associated pelvic pain, and that TMPA, COCs, and NSAIDs, and other progestin-containing pills are considered as the top second-line options for EAPP. So that's it for this lecture. Thank you for your kind attention.
Thank you so much, Dr. Ina, for that interesting perspective on the medical management of endometriosis. So before we have the open forum, I think BSP would have some short poll questions for our audience. Go ahead, please refresh your page for the poll questions. Kindly answer the poll questions from BSB. Okay, so I hope everyone was able to key in their answers into the poll. Okay, without further ado, I'd like to invite our speakers, Dr. Basma Darwish and Dr. Ina Iraban, to kindly join me in the virtual floor for the open forum. So I hope everyone was able to key in their answers into the poll. Okay, without okay, thank you. Thank you so much for the insightful lectures, Dr. Basma and Dr. Ina. So for our first question, actually there's a few questions here on surgical management of endometriosis. I know this is not part of the scope of our discussion, so let me ask these few questions first. Dr. Basma, having worked in the endometriosis center, there's one attendee who'd like to ask the common indications for surgical management for endometriosis, and if in your center, do you have a cutoff size for endometriomas?
Okay. So I would say that this is a very vast and open question. But what I want the audience to know is that, surgery or any treatment for endometriosis should always be tailored according to the patient's symptoms and according to the patient's need. So as I mentioned, for superficial endometriosis, usually surgery is not our first option. And even though we can resect some lesions and we can cauterize, but the effects or the benefits are very short term and they are not at all long term. So usually the indications are more for those who suffer from deep infiltrating endometriosis, but also with caution. So you should tailor them according to the needs, symptoms, and what benefits you would obtain, and I mean the patient would obtain, in improving the symptoms. So number one, is your patient symptomatic, for example, and would the surgery improve the symptoms? Because we have to know that sometimes the surgery, and let's say, for example, if I speak about rectal endometriosis and if there is a rectal nodule, so sometimes the patient is symptomatic because of the presence of a rectal nodule, but sometimes we can even worsen the symptoms by a surgery on the rectum. So I would say that the indications for surgery, generally speaking, would be when we have a deep infiltrating endometriosis, for example, those that are infiltrating the rectum, the bladder, the ureters, or maybe even the diaphragm, in patients who are symptomatic and in whom surgery, in my opinion, would add benefit to the patient. Other things would be, let's say, if, delaying surgery would result in more complications or would result in more symptoms to the patient. So let's say a very big nodule that would lead to obstruction in no time. So of course, I would not let the patient go to that stage and then operate on her in an emergency situation. But of course, I would want to operate before. Another very important deep infiltrating endometriosis is those which infiltrate the ureters, because this can lead to silent hydronephrosis and silent loss of the kidneys. So we should be very careful about ureteral endometriosis. And I think that surgery does play a good role in this part of the endometriosis. And another thing is also, for example, in cases where I would be able to provide more conservative type of surgery. So let's say if the lesion is of a smaller size and my surgery would be more conservative, instead of leaving the patient going into a very huge nodule, that would lead to a more radical type of surgery. So to summarize, it is tailored according to the patient's symptoms and to what the surgery would be able to provide in sense of improvement in symptoms, pain, function, and also in the type of conservative surgery that I would be able to provide for the patient.
And Dr. Buku, can I add just one indication that I
Go
think
ahead.
is also very important? Okay. We also consider surgery for patients where you have some doubt regarding your imaging of an OMA. If you're considering probably a malignancy, you're not very sure if it's a malignant a tumor, ovarian cyst, or whether it's really an endometrioma, then maybe you can consider surgery for those cases.
Sure.
Yes,
That's a very important indication. Yes. And maybe just we forgot to answer the question about the size of the endometrioma.
Yes, that's right.
So also speaking about endometriomas, what is important to me also is where the endometrioma is found. Because if the endometrioma is found on the left side, where it is in close contact to the rectum, then maybe I would operate a little bit earlier than an endometrioma, which is found on the right side, where we do not have the rectum in close contact. Because an endometrioma on the left side in contact to the rectum can also lead to rectal implants and rectal endometriosis. Just speaking of a cutoff, we can say that anything 5 centimeters or above is considered, I mean, significant, and we can operate on an endometrioma of that size.
But the international guidelines don't recommend a size cutoff anymore, Dr. Basma?
Yes, they don't recommend a size cutoff. I know that, but I mean, what we do now is that they're still not, I mean, new guidelines, but we have spoken a lot about them. Is that, I mean, we do not strip endometriomas anymore. I've spoken about that a lot in so many lectures. But I mean, we use laser therapy, and if the endometrioma, I mean, if we leave it and it is quite big enough, then treatment would be a little bit difficult. So of course, I mean, there is no cutoff as long as you follow up your patients, so that, I mean, we don't reach a state of a huge endometrioma, which would be very difficult to treat later on.
Thank you for your input, Dr. Basma and Dr. Ina. I think that's what makes endometriosis such a difficult disease to treat, because it's not, it's not just one treatment for each patient with endometriosis. Everything is individualized.
There are lots of gray areas then, no, Micah?
Yes. So, Dr. Basma and Dr. Ina, while we're on the topic of endometrioma, you mentioned in your lecture, Dr. Basma, that you, in your center, you give preoperative GnRH agonist treatment prior to surgery. How long do you give the treatment prior to surgery?
Yeah, so as I mentioned also before, that, I mean, there are no studies. I mean, so we cannot base our just experience and observations on studies, but just by experience. So, I mean, in any deep infiltrating endometriosis surgery, so I'm not talking about the superficial ones, but when I'm going to a major surgery, it is a treatment of at least 3 months before I go to surgery. And if we believe that, I mean, the surgery is going to be very challenging, if we are in face of a frozen pelvis, for example, we can push it up to 6 months before proceeding to surgery, because it does, in our opinion and in our experience, reduce the inflammation and the friable tissue which we can face in surgery. So it makes the surgery a little bit easier, and of course it makes the complications and the morbidity less.
Thank you. We have a question from Dr. Torres. Dr. Torres, you're raising your hand, please.
Go
ahead.
So corollary to your question, Micah, Dr. Darwish, when you give your preoperative GnRH agonist, it's going to make the lesions inactive, right? So it's going to facilitate the surgery. But a consequence of that is that you might be able to, let's say, for example, you're dealing with a huge nodule and you want to resect as completely as possible. But if you suppress, so the lesion is inactive, it's going to shrink that lesion. So is there a danger of having inadequate margins of resection, and it can be a focus of recurrence later on? What's your opinion on that? Thank you.
It's a very nice question, and I really like it. So, I mean, endometriosis is not a cancer. So we do not need to achieve, let's say, like microscopic negative cells in endometriosis in contrast to cancer. So endometriosis is not a cancer. And we have published some studies which I can share with you. So we have 2 studies which were published about the bowel occult microscopic endometriosis and resection margins. So we had, this was with a complete resection, we had up to 14% of occult endometriosis cells at the margins of the rectum, following surgery, but with no impact on recurrence and no impact on the symptoms. That was one study. And then there was another study where we had to do a mapping of the microscopic occult endometriosis cells after rectal resection of endometriosis tumors. And surprisingly, we found microscopic cells as far as 5 centimeters from the from the rectal margin, where we thought that we had done a complete resection. So in my opinion, shrinking the nodule to a smaller size or trying to obtain a resection, as complete as possible, trying to take in all the microscopic cells is something that will not be achieved, and we do not need to achieve it because we are not dealing with cancer. So in endometriosis, what we believe also is that the surgery should be as conservative as possible, because what is important is to conserve function, and we shouldn't forget that we are dealing with young women who should have a function conserved.
Thank you very much, doctor. That's very reassuring to know.
In your lecture, Dr. Basma, you mentioned data on prolonged use of GnRH agonists with add-back therapy, especially in the case of the lesion on the episiotomy site. For deep infiltrating endometriosis, is medical management, long-term medical management, an option, or is there really need to do surgery?
So I think this is what I shared with you at the end, the measure, or the mesure in French, as I said, study would tell us, because this is the study where it would contain, it is a randomized controlled study, and it would compare, women who would undergo surgical treatment versus women who would undergo complete medical treatment for rectal endometriosis. But just by experience, if you have a rectal nodule that is asymptomatic, let's say a small rectal nodule that is asymptomatic, maybe I wouldn't go and jump on a lady and interfere surgically, because as I said, and it is very well documented, that post-surgical unpleasant digestive symptoms can happen because of surgery. So imagine a patient who is asymptomatic, why would I want to put the burden of surgery and give her some new digestive symptoms while she was asymptomatic? The only thing is that, of course, the treatment option, we know that the medical treatment option is something that is temporary. Once you stop the treatment, the lesions can keep on growing. So of course, it depends on the age of your patient. If you have a patient that is approaching menopause, you can continue treatment with follow-up. I would always say with follow-up, because continuous medical treatment also does not 100% control the disease. It does not 100% result in regression of the disease, because we have also published some cases in which patients were on continuous medical treatment, and in spite of that, the disease has progressed. And this especially happens in cases where the disease is severe and the nodules are large enough, so they could be resistant to continuous medical treatment. So I would say that yes, it remains an option in those who are asymptomatic and lesions who are small, but with follow-up, and in patients in whom you can put, the treatment in a continuous status. So those in whom, the age is close to maybe menopause.
Thank you. This next question is addressed to both Dr. Basma and Dr. Ina. What is your favorite add-back therapy when you give your GnRH agonist?
Oh, I give Tibolone, 2.5 milligram OD, or I can also give, sometimes I give MPA, and I know some of my colleagues give Neta and ETA, 2.5 or 5 milligrams OD.
Yeah, that's right. There is no consensus about what HRT you can give. So Tibolone is a very good one, and I sometimes give only estrogen alone as a gel because it is better tolerated by the patients than tablets. But there is no consensus on which is better than the other.
Thank you, doctors. One question for Dr. Ina: how do you give the aromatase inhibitors?
Okay. I think that's from Dr. Miko.
Dr.
Miko, the studies that were included from those from where the guideline development group based their statements from, they used 5 milligrams of aromatase inhibitor, that's letrozole, per day for at least 3 to 4 months before they measured any outcome. Okay, so at least 3 to 4 months, 5 milligrams per day.
Okay, ma'am. And this is in conjunction with the GnRH agonist and the pills, or I've read
just letrozole. Just letrozole.
Oh, just letrozole. So I think I read one study that they gave it
with,
together
with the GnRH agonist.
Like
yes.
I said,
I also saw that. Also saw that study.
So I think we've addressed most of the questions already. So to wrap up this session, any take-home message for our audience? Dr. Basma, would you like to go first?
Yes, I mean, there are so many take-home messages on this day. I think that, I mean, in the previous era, endometriosis was a disease that was not, I mean, diagnosed easily. So patients would visit many doctors, as much as maybe 17 doctors, physicians, family physicians, and specialists before, I mean, diagnosing the disease. So I think that before all, we should listen to our patients. We should listen to the women who suffer from I mean, pelvic pain, even if the results come out to be negative, because we know that at the beginning of endometriosis or in superficial endometriosis, all the workup can come out to be negative. And we shouldn't just, I mean, tell them that there is something going on in the head, because we now see that, I mean, chronic pelvic pain, yes, I mean, it starts in the pain, I mean, it starts in the head because it is a central type of pain, and we should believe them, and we should take that seriously, and we should follow up on those patients. Thank you.
Thank you, Dr. Basma. Dr. Ina?
Yes, I think the very important key concept here would be to understand that endometriosis is a chronic inflammatory disease, and it's a lifelong disease that requires lifelong management, and that the pain symptoms should be treated without delay to avoid central sensitization. And lastly, medical treatment should be the first therapeutic option, no, rather than surgery, especially if we're dealing with endometriosis-associated pain. That's it. Thank you, Micah.
Thank you. Thank you. At this point, we'd like to sincerely thank both our speakers, Dr. Basma Darwish and Dr. Ina Iraban, for such enlightening lectures. Dr. Basma, I know in France there's already a law on endometriosis, and hopefully here in the Philippines we can lobby for also a law and increase awareness of endometriosis.
Hopefully, and I mean, I would be ready with the team to help in, I mean, in anything that you would need to set up. I mean, any endometriosis specialized centers, for example, or to put in some guidelines.
Thank you so much.
Thank you for having me.
So with that, unfortunately, that's all the time we have. Thank you again. That was such a lively discussion. We would like to call on the business unit head of PSP Bioscience Philippines Incorporated Women's Health Division to formally close this evening session. So Ms. Christine Magada, the virtual floor is yours. Go ahead. Ms. Christine, you could go ahead with your closing remarks.
Good evening, doctors. I am very much delighted to be with you in this meaningful event. Meaningful because we chose to celebrate the Endometriosis Awareness Month by bringing to you on this virtual stage experts who so willingly shared with us how to positively control this negatively life-impacting chronic disease. I would like to thank our speakers for tonight, our very own from the Philippines, Dr. Ina Iraban, and our foreign speaker, Dr. Basma Abdurrahman Darwish. Many thanks also to our moderator, Dr. Micaela Erlinda Martinez Buku. Of course, this event would not have been possible without the PSRM, headed by its president, Dr. Debbie Megiso. Thank you very much to you, Doctor, and the organizing committee. You can trust that we at BSV are one with you in your efforts in managing and controlling endometriosis by providing quality patient care with our own brand of Luprolide, Luprodex. Luprolide, such as Luprodex, is an effective treatment for pelvic pain due to endometriosis, as recommended by the PSRM, ASRM, ESHRE, and the World Endometriosis Society. Should you have any interest or concerns in Lubridex, you may approach our BSV medical representatives in your area. Once again, thank you very much for this opportunity and keep safe, everyone.
Thank you so much, BSB. And thank you everyone for attending this CME webinar. I know there's no cure yet for endometriosis, but thanks to doctors like Dr. Basman, Dr. Ina, our knowledge about endometriosis continues to evolve. So for now, let us continue to raise endometriosis awareness so we can help women tackle this debilitating disease. So thank you everyone and have a good night.
Okay, the live has been stopped. Thank you everyone.